Hi, my name is Kevin Herzog, and we're going to go over the female reproductive system, and we're going to get into ovarian cyst. We're going to try to understand their causes, symptoms, and learn how to manage them. All right. So first, I have to hit some admin. First, you should be in a safe environment, so you shouldn't be actively under fire or on fire. If that is the case, please call 911 or your local emergency services. The classroom considerations is I don't know why you'd be in a classroom for this. You should be in a well lit study with some nice snacks, ready to learn, and with a low risk assessment. The dissemination for all of this is just unclassified material. You can disseminate it. Moving forward, here are the references I used for my project. I leaned very heavily on Martini's Fundamentals of Anatomy and Physiology. I think it's a great textbook. Breaks everything down to a pretty manageable level. The Mayo Foundation gave me a lot of good audiovisual resources, and the real winner that I go to all the time is this website called Up to Date. It does have a paywall for the more in-depth articles, but there is a public-facing portion of it, and I recommend it to anybody that wants to investigate any type of pathology instead of going to don't go to WebMD. You're gonna find out you have cancer. Up to Date is a much better resource. Okay, so here is our first terminal learning, or this is our terminal learning objective, which is I'm going to educate you on the reproductive system and about ovarian cyst. I'm going to do it in a didactic presentation, and hopefully at the end of this, you're going to understand the female reproductive system and what are ovarian cysts and what can be done to manage them. I can't confirm your learning unless you want to comment in the comments. Otherwise, I hope you're going to get something out of this. Okay, so, ELO number one. We're going to go over the basics of the female reproductive system. Just a little whistle stop tour. I'm going to do this in a little didactic block of instruction with visual aids, and hopefully you're going to understand north, south, east, west, what we're doing around here. Sound check, sound check, sound check. Sorry, almost thought I lost you guys. Okay, so here's an AP view of the uterus. We're going to mainly be focusing on the uterus. The external reproductive portions of the organ just really aren't part of the purview of this course. We're going to be mainly focusing on the uterus, the ovaries, the uterine tube, the fimbriae. So with that stated, the ovaries are the primary reproductive organs. They store immature eggs, which are called oocytes. If you think of uovo, like Italian for egg, maybe it's easier for you to say. And release one each month during ovulation. Ovaries also produce estrogen and progesterone, hormones that regulate the menstrual cycle and prepare the body for pregnancy. From the ovary, the eggs enter the fallopian tube. This narrow, muscular tube is the site of fertilization if sperm is present. The egg or fertilized zygote is then transported to the uterus. The uterus is very muscular. It is a muscular hollow organ where the embryo implants and develops during pregnancy. Its inner lining, the endometrium, thickens each cycle under hormonal influence, and it gets prepared for implantation. If fertilization does not occur, the endometrium sheds during menstruation. I think one of the best ways to think about it is think about a greenhouse, which is the endometrium lines itself with fresh soil, and if an egg does not implant that month, it literally contracts the muscle in like a wave. Think of the worst Charlie horse you've ever had, or the most intense like flex you've ever done. That is what the uterus is doing to flex that soil out. Next slide. So that's the uterus right there. We're going to go on to ELO objective number 2, which is define what ovarian cysts are and how they are managed. Again, this is going to be another didactic block of instruction with visual aids, and hopefully you guys get a nice understanding of what's going on. So there are different kinds of cysts. So ovarian cysts are fluid-filled sacs that develop in or on the ovary. They're common of women of reproductive age, and remember, as clinicians, reproductive age is younger than you think and older than you think as well, which is why almost everybody we need to do a pregnancy test when they come on in. So cysts are broadly divided into functional cysts, which this is just normal ovary function that maybe had a little bit of a short circuit, and non-functional cysts that they're indicative of bigger pathology. So follicular cysts are the most common type. They occur when a follicle, which is normally released as an egg, fails to rupture. Instead, the follicle fills with fluid and expands. These cysts are usually small, painless, and resolve with a few menstrual cycles. Corpus luteum cysts form after ovulation. Normally, the follicle transforms into a corpus luteum that produces progesterone, and it seals and accumulates blood or fluid, and a cyst can develop. Corpus luteum cysts sometimes rupture and cause sharp pelvic pain, but they generally resolve on their own. Both follicular and corpus luteum cysts are considered functional cysts because they result from, like I said, normal activity. Any type of bleeding is usually bad. So hemorrhagic cysts are when bleeding occurs into a functional cyst. They often cause sudden unilateral pain and may lead to abdominal irritation if they rupture. Remember, we should not be bleeding. Most are self-limited, but significant bleeding does warrant a trip to the urgent care or to the emergency department. Endometriomas are also called chocolate cysts, and I don't know what type of chocolate you're eating, but this is why they're called that. They develop when endometrial tissue from endometriosis grows onto the ovary, and then over time this tissue bleeds and collects into a thick brown fluid. These are linked with chronic pelvic pain and potentially linked to infertility, and so usually they require a consult to OB and then probably a consult to surgery to remove. And then dermoid cysts. Basically, let's see, these arise from germ cells that can differentiate into multiple tissue sites, multiple tissue types. These ones, they can contain hair, they can contain skin, they can contain fat, and horrifyingly, they can contain teeth. I'm glad I put that in your mind. Although typically benign, dermoid cysts can grow larger and they can twist the ovary, so surgical removal is often recommended. So here's, I know this is a complex one, but basically the menstrual cycle has two main phases. We'll go to this part. There's a follicular and luteal phase. During the follicular phase, follicles grow, and if one fails to rupture, a follicle cyst can form. Around day 14, ovulation occurs with an egg release. In the luteal phase, the follicle becomes the corpus luteum, which sometimes seal and fill with fluid or blood, leading to the corpus luteum or hemorrhagic cyst. Meanwhile, the endometrium thickens under hormone influence and sheds if no pregnancy occurs. The cycle shows why most functional cysts develop mid-cycle. Moving on. So, diagnosis. Most diagnosis is done with ultrasound, and ultrasound is an art. I can't do it. I've only been trained on EFAST, and basically you have to have just the perfect soft hands. So generally when somebody comes in complaining of pain below the belly button and we suspect that it's going to be cyst pain, we're going to send them to ultrasound, and ultrasound is going to do their work. Now, when ultrasound comes back and shows us a cyst that's under 5 centimeters, they're generally benign. Cysts that are over 7 centimeters, and I'm sorry, but this is science, this is medicine, so let's use science units, are causes for concern and may require your patient to be referred out to OB/GYN or surgical consult. Again, ultrasound is the way this is all done, and you should do a pregnancy test before you send them to ultrasound. Basically, you should do a pregnancy test as a matter of course at point of care testing as soon as somebody walks in. So, treatment recommendations. Okay, so first one is we're going to do some lifestyle recommendations. So, cigarettes. Cigarettes are cool. They're fired by your face. They give you something to do with your hands. They allow you to take tons of breaks while all your healthy people have to stay working. However, they negatively affect just about every single organ system, and the reproductive system is no exception. So while nobody can exactly tell why, basically inhaling carcinogens in smoke seems to just be a bad thing. And in this case, it seems to affect estrogen and progesterone metabolism, which screws with the feedback loop between the ovary and pituitary hormones. This is in addition to smoking reduces blood flow, and reducing blood flow to the ovaries is just a bad idea. So for a patient with cyst, first off, you need to, if they have a smoking habit, you need to recommend that they stop. Moving on, the go-to thing we recommend for these cysts is non-steroidal anti-inflammatory drugs. Now, most people are going to turn up their noses towards ibuprofen, acetylsalicylic acid, or naproxen, mainly because they're over the counter medications. And part of this is most people use these wrong. They generally you have to take enough to get a therapeutic effect, and usually this therapeutic effect develops over 3 to 4 days. And so if you tell a person in acute pain that they have to wait 3 to 4 days, they might not take you seriously as a clinician. So to overcome some of this skepticism of you as a clinician, if you have access to ketorolac, which is an NSAID, I would recommend you use it, mainly because its use as an IM or IV medication, A, immediately affects the patient, and B, because it's in a vial, it's injectable, the patient will take it as a more serious medication, even though, between you and me, it's just an NSAID. Other things we need to talk about is we need to talk about contraceptive methods. Basically, hormonal birth control pills can reduce the function or the risk of functional ovarian cyst, and this is because they work by suppressing ovulation. And since most cysts form by follicular cells, anything that changes the hormonal system of the female reproductive system would be beneficial. Again, you can't just treat all patients as a one size fits all thing. Mainly because we need to treat the patient. Some patients can't tolerate hormonal contraceptives. Sometimes they come with an increased risk of blood clots, or some patients just don't tolerate the pill, and we don't want to endanger our patient's life. And so sometimes we need to approach our patients in a holistic viewpoint, which is sometimes they might need to reduce some of the comorbidities associated with hormonal birth control, which could be excessive BMI. Again, smoking, which we already covered, is just terrible for you, before we can actually give them hormonal birth control. If they want it, it's their choice. Um, so that is the conclusion is ovarian cysts are common and usually benign. You still need to take the patient's pain seriously, and you need to take any patient coming in with pain below the belly button and they're female, you need to also take it extremely seriously until a life threat is ruled out. Patient education about lifestyle decisions and contraceptives is an important way we could tackle this. And then be aware for your follow-up criteria, which is in this case anything above 7 centimeters. Um, Please put your questions in the comments. And my name is Kevin Herzog. And this concludes my block of instruction. Thank you very much.